Hashtag the economics of inequity. Why your health insurance can still be useless. Imagine paying $15,000 a year for insurance. Then you have a baby, and the covered bill is $47,000. By the end of this story, you'll understand why U.S. healthcare feels like a rigged game and why even good insurance can still wreck you financially. The American healthcare consumer lives in constant financial risk, even with insurance. Especially with insurance, because the real trap is not no coverage. The trap is how billing works and how prices get invented. In-network hospital, planned C-section, total bill $47,091. The gap between insured and safe is massive. A C-section is a common, standard procedure, yet the final itemized bill can look unreal. Often, the surgery is not the main cost. The surrounding facility charges are: one recovery room charge can be billed at $12,000. Room and board for a maternity stay can add $5,600. 4 doses of IV Tylenol can be billed near $4,000. That is thousands of % over retail cost. Some hospitals have charged for skin-to-skin contact with your own newborn. Yes, really. These are not rare glitches. They are predictable outcomes of the system. Standard care can be turned into a billable procedure, and patients only learn after the fact. A free annual checkup can still generate a $1,430 bill because follow-up questions can reclassify the visit. It becomes diagnostic, not preventative. That single coding change flips the price. Insurance does not guarantee predictability. It only changes who you argue with. A vial of saline can cost a hospital about $1. You can be charged $100. That is the logic of the chargemaster world. Here are examples of billed prices versus market value. These are the kinds of gaps patients see on itemized bills. IV Tylenol, 4 doses, billed $4,000. Market value under $50. Approximate markup 7,900%. Measles vaccine, billed $1,400. Market value about $280. Approximate markup 400%. A 39-mile ambulance ride, billed $9,250. Market value under $2,000. Approximate markup 362%. Routine lab work, billed $2,400. Market value about $600. Approximate markup 300%. Saline solution, single vial, billed $100. Market value about $1. Approximate markup 9,900%. You pay $500 a month in premiums. Now pay another $2,000. Only then does coverage start to kick in. Even when charges are correct, people get crushed by cost sharing. The biggest barrier is the deductible. It is the amount you pay before insurance pays. For many employer plans, deductibles are now over $2,000 per person. Family deductibles can be 2 or 3 times that. So insurance becomes a disaster-only backstop, not a tool for everyday care. Even after the deductible, you can still owe nearly $10,000 in a year. For covered services, after the deductible, many plans move to coinsurance. That often means paying something like 20% of the allowed amount. You keep paying until you hit the out-of-pocket maximum. That maximum can be as high as $9,450 for an individual. So an insured person can still owe close to $10,000 in a year, and that can happen without anything out of network. They tell you an MRI will cost $450 today. 3 months later, you get a bill for $3,200 more. Many clinics collect an estimated copay up front. Then the real bill arrives later. Sometimes it is weeks later. Sometimes it is months later. The estimate was not the final number. Coding can change the final amount. Insurance adjudication can change the final amount, and the patient is left with the surprise. This creates constant financial anxiety. It also pushes people to delay care, especially people already carrying medical debt. Deductible, a fixed annual amount you pay first. Impact, big early year bills. Co-payment, a fixed fee at the visit. Impact, predictable for routine care. Impact, sometimes does not count toward the deductible. Coinsurance, a percentage you pay after the deductible. Impact, painful for expensive tests and procedures. Out-of-pocket maximum, the most you pay in a year for covered in-network care. Impact, still high enough to put families into debt. Every hospital has a master price list. It's not designed to be fair. It's designed to be high. Hospitals maintain a charge master. It lists a gross price for every service and supply. Those prices can be wildly inflated. They often have little relationship to actual costs. They also differ from what Medicare pays. Insurers negotiate discounts off these gross numbers, but the sticker price is the starting point. And it can hit patients hardest when care goes out of network. Sometimes without the patient realizing it. Same doctor, same exam room, same 5-minute visit. Suddenly it costs 3 times more because a hospital bought the building. Facility fees were meant for hospital-level overhead, but they have spread into routine outpatient care. This happens when hospitals buy independent practices. The clinic can be reclassified as a hospital outpatient department. Then the billing splits into 2 charges. One is for the doctor's work. One is a facility fee for using the space. The care did not change. The ownership changed. The price explodes. A biopsy can jump from $146 to $791. Same procedure, same doctor. That is a 442% increase. Examples of site of service price jumps. Cardiac ultrasound, independent office, $164. Hospital-owned clinic, $339. Increase, 107%. Chemotherapy, 1 hour. Independent office, $237. Hospital-owned clinic, $646. Increase, 173%. Primary care visit. Independent office, $116. Hospital-owned clinic, $217. Increase, 87%. Routine lab test. Independent office, $18. Hospital-owned clinic, $68. Increase, 278%. Biopsy, independent office, $146. Hospital-owned clinic, $791. Increase, 442%. You spend $100 on a prescription, the drug maker keeps about $41. So where does the other $59 go? Pharmacy benefit managers sit in the middle of drug pricing. They connect manufacturers, insurers, and pharmacies. They design formularies. They negotiate deals. The biggest controversy is rebates. Manufacturers pay rebates for preferred placement, but rebates are often tied to the list price. Higher list price can mean bigger rebate dollars. That creates a nasty incentive. The system rewards expensive drugs, even when cheaper options exist. Because bigger prices can mean bigger kickbacks, this is often called the rebate trap. Patients can be charged based on list price, even when the net price is lower after rebates. The patient pays at the counter. The rebates move in the background. The same company can insure you, manage your prescriptions, and own the pharmacy. Guess who wins? Vertical integration supercharges the problem. Major PBMs are tied to major insurers. Sometimes they also own pharmacies. So one corporate group can profit at every step. It becomes a closed loop. Money moves inside the same family of companies. And the patient still gets billed like none of that exists. Manufacturer gets about $41, keeps a smaller amount after production and overhead. Insurer or plan sponsor gets about $19, keeps a slice as profit. Retail pharmacy gets about $15, keeps a slice as profit. PBM gets about $5, keeps a slice as profit. Wholesaler gets about $2, keeps a smaller slice as profit. Production costs about $18. Notice the pattern. Middle layers can capture more than the maker's profit. In 2024, about $4.9 trillion flowed through U.S. healthcare. That's roughly 18% of the economy. So where does it go? Step 1, the patient. Money enters through premiums. Money also enters through out-of-pocket costs. Step 2, the insurer. Insurers collect premiums. They manage networks and negotiated rates. They also contract with PBMs. Step 3. The hospital and providers. Hospitals get paid by insurers. Hospitals also bill patients directly. For every $1 spent on care, hospitals can spend almost $2 on administration. That means billing, coding, collections, and bureaucracy. Step 4. The pharmacy loop. PBMs process claims. Rebates flow after the sale. Patients can pay more in copays than the net price because the net price is hidden. Americans spend over $1,000 per person each year on healthcare paperwork, not on treatment. On paperwork, administrative waste is a giant cost driver. It is fueled by complexity. Thousands of plans exist. Each plan has different rules. Each plan has different networks. Each plan has different codes and approvals. This complexity requires a huge bureaucracy, and patients ultimately fund it. Estimates often place administrative costs at 15 to 30% of spending. Per person administration in the U.S. is over $1,000. That is several times higher than peer countries. This is money that does not provide care. It buys friction. Hospitals bought thousands of doctor practices fast. Your doctor may not be independent anymore. Consolidation changes pricing power. Hospitals merge. Hospitals buy physician groups. Markets become dominated by a few systems. Negotiations become take it or leave it. When one system dominates your region, it can demand higher prices. Insurers can't easily refuse. Patients can't easily escape. Research consistently links consolidation to higher prices. Prices can rise meaningfully after mergers. Outcomes do not reliably improve in proportion. The system gets bigger. The bills get bigger. Your hospital-employed doctor may not be free to refer you, even if the cheaper place is across the street. Owned systems can steer referrals. Patients get directed to system-owned imaging centers. Patients get directed to system-owned surgery centers. This can happen even if alternatives are cheaper. It can happen even if alternatives have better quality. Steering locks spending inside the system. In 22, surprise billing got partially attacked. But one huge loophole stayed open. The No Surprises Act added major protections. Emergency care is generally billed at in-network cost sharing, even if the provider is out of network. Air ambulance surprise bills were addressed. Out-of-network clinicians at in-network hospitals were addressed, but ground ambulances were left out. That gap matters a lot. Call 911. Get a $9,000 bill because the ambulance was out of network and you had zero choice. Ground ambulances are a patchwork. They can be private. They can be municipal. They can be contracted in strange ways. Patients cannot choose which one shows up, yet patients can still get out-of-network bills. A large share of rides can be billed that way. Transfers between facilities can be especially expensive. The high cost is not a bug, it's a feature. The system is built to extract money from patients. 3 forces drive the insured but broke reality. Reason 1. Consolidation plus facility fees. Ownership changes can double prices. Facility fees act like a hidden tax, and dominant systems can demand higher rates. Reason 2. PBM opacity and rebate incentives. Rebates are secret. Patients pay based on list price. Middlemen benefit from higher spending. Vertical integration removes pressure to lower costs. Reason 3. Administrative burden. A massive share of spending funds bureaucracy. Not nurses. Not doctors. Not care. You pay $15,000 a year in premiums, then $2,000 in deductible, then 20% coinsurance, and you can still end up in debt. The U.S. healthcare system functions as nested profit centers. Coverage is often a ticket into a confusing marketplace. Prices are inflated. Rules are hidden. Risk is shifted onto the individual. Until consolidation, administrative waste, and opaque middlemen are tackled, insurance will stay an expensive illusion for millions of families.